And I wanted to welcome Dr. Jones again. Thanks so much for rejoining us. Dr. Jones did a training for us a little while ago, and she's back, and we're really pleased to have her. And I'm going to go ahead and read her bio real quick. Dr. Jones, PhD, a native of Hayward, California, earned her doctoral degree in counseling psychology at Oklahoma State University. During her graduate training, Dr. Jones worked for the state of Oklahoma in their juvenile affairs department, conducting full assessment batteries and providing mental health treatment to incarcerated youth. Dr. Jones spent 4 years as a licensed psychologist at Kaiser Permanente in the Addiction Medicine and Recovery Services Department, working with adults and specializing in adolescents with substance use concerns. In this role, Dr. Jones assisted in the development of multiple adolescent drug and alcohol programs. Dr. Jones spent 2 years as a clinical services supervisor at Rogers Behavioral Health, where she co-authored various manuals to be utilized nationally throughout the system for the mental health and recovery service line. Dr. Jones has taught addiction courses at Palo Alto University and UC Berkeley Extension, and served as the board chair for a local nonprofit in Oakland, Centerforce, serving the reentry population and their families, and serves on the Miles Hall Foundation board to advocate for reducing killings of BIPOC members during mental health crises. Currently, Dr. Jones is the founder of Steady LLC, clinical consultation, training, and development services, and in addition, carries a small caseload of individual clients. We'd like to welcome you, Dr. Jones. Thanks so much for being with us today.
Thank you so much for having me, Leah, and thank you all for being here. I'm going to go ahead and start my screen share. Can everyone see that okay? Or Leah, maybe you can be the representative.
Looks great.
All right, perfect. All right, welcome everyone. Thank you so much for being here on this Friday morning. This training is going to be an introduction to substance use treatment in community settings. And before we start anything, what I'd like to do is present a land acknowledgement for Contra Costa County. That's where I'm located. For those of you who are not familiar, land acknowledgement is a formal statement that recognizes and respects Indigenous peoples as traditional stewards of this land and the enduring relationship that exists between Indigenous peoples and their traditional territories. So this particular, the Contra Costa County is Bay Miwok, and please forgive my mispronunciation if that is not how it's pronounced. That's what I found and what I looked up. So that is the land that I am presenting on today. And I wanted to make sure that I put in a formal statement of acknowledgement for those who came before me and those who have tended to this land such that we are able to do what we do on it. Also, I have no financial affiliations with any entity that is mentioned or will be mentioned in this training. This is purely informational, so I'm not receiving any financial benefit from the companies that I may discuss or the organizations that I discuss in today's training. So I wanted to start with a little bit about me. I thought it was only appropriate to start with the fact that this is a first 5 training and I am actually 35 weeks pregnant. So I am well on my way to delivering this baby. And I think it's unique in that this is something that I am already very passionate about, but have a particular investment and interest in currently, given my pregnancy and this process and this journey, and some of the things that came up for me during this process that I was not expecting to happen, and found out as these things happened how common they actually are, and how the intersectionality between pregnancy and substance use and postpartum and substance use really kind of play a role together. And we'll get into that much later in the training, but I just wanted to share that my story is influenced much by the fact that I'm currently pregnant and on the last leg of this journey. With regarding to my training and background, Leah talked quite a bit about it. Just to give a little bit more context, I still work for Rogers Behavioral Health, but I started my own business that does clinical consultation, training, and development, because I realized in the midst of all of these things and baby expectations and COVID and all of that, that I felt like I had more to give, and I felt like I had more to offer my community in the context of my profession. And also that there's not a lot out there with regard to how to do culturally responsive treatment when it comes to substance use with families. And as Leah mentioned, many of you shared that you want to learn more about how to kind of help that population, the subgroup, and how do we even know if people are using substances, and also just to dismantle some of those stigmas that come along with people who do use substances. So my organization, my company, really focuses on consultation for organizations, for groups, to revamp or to look over their current practices and see what's working and what's not working. We do program evaluation, program development. So as mentioned, I definitely am familiar with program manual writing and program development. I also do trainings such as these for professional development for nonprofits. And I do see a small group of individuals for culturally responsive treatment. So not limited to substance use, because I'm still a licensed psychologist and can see many, but my approach is more culturally responsive in nature and culturally humble in nature, and I try to be. So I see myself as a forever learner, and this organization company that I've developed is my baby as well. So essentially I have two babies that are kind of coming out of this journey that I've been on. So if you'd like to contact me individually, I do individual clinical consultation as well for those of you who may see your own clients individually and you're looking for some consultation. I do that as well. My website is listed here, as well as my email. You should be able to get access to me through either of those avenues. So before we even get started into the training, one of the things I really like to do is help people kind of get their mental juices flowing and have conversation. So we're going to start with a breakout group. I know that many of you filled out the pre-survey and some of the questions are similar, but what do you hope to get most out of this training? What knowledge are you already coming in with? What do you already know? What do you feel comfortable with? What do you think is, if I heard this during this training, it would be kind of a waste of time? And what are some initial questions that you have? This will be helpful because once we get to the end during the question answer session, if those questions have not already been answered, that gives me an opportunity to work through and answer them. So we'll be in the groups for about from 9:15, so 9:20, we'll pull you back in. Leah, if you want to break people out, that would be great. All right, welcome back, everyone. We are going to have a brief large group discussion. If anybody is willing to share what they went through or what they talked about in their small group, that would be great. You can either pop it in the chat or you can just unmute yourself, whatever works for you. And thank you all for the congratulations, for the congratulatory messages. I appreciate it.
Hi, Gabrielle. This is Hannah. I'm with the Monument First Life Center in Concord. And I had one of our breakout room mates couldn't talk. We didn't have enough time. But what we talk about is the basic. What was the first question? Wait, I forgot.
I can go back to the questions
there.
for you.
Congratulations first to you, Gabriel. We wish you the best for your the years of the pregnancy and your first few months and the years.
Thank you.
It'll be fun. So I am here as a part-time teacher and trying to connect more with the parents. Responsibilities are coming in. So I think this is an aspect of teaching where I haven't totally approached. So I do not have much knowledge. What we were speaking about are my other breakout roommates that I do not have much experience on talking professionally with parents. I really hope nobody comes in. That means it's a good sign. But for currently, we do not have much professional experience on interacting with parents and reaching out, connecting with them, helping them out more professionally. So that's where I would like to get most of my out of the training. That's the most I would need. And also differentiating between abuse and addiction. It is how it affects their surrounding.
Mhm.
And that's, I think, basically the knowledge that I have is also what we were discussing is we don't have anybody close to us, which is touchwood also good, but all I know is it's not good for you. And also for your surrounding, it breaks you out from the environment that is around you. That's the basic knowledge I am just coming in with. And for now, we didn't have that many initial questions because I think we didn't have much knowledge. So I think once you start getting in, then you start asking, oh, what is that? What is that? So none for myself, none of the initial questions currently though.
Okay, thank you.
Thank you.
Yeah, that is definitely something that people come in with is, I don't know how to even assess to begin with, to know if people are using substances. Somebody popped in the chat how to get someone to stop smoking marijuana or using cannabis while they're pregnant. And we will talk a little bit about harm reduction. I have a whole training on prenatal and perinatal substance use that I have done with First Five and would be happy to do again. And I also have a whole training on adolescent specific substance use with interventions and treatment and how to recognize it. So there are several deep dive trainings that I do around some of that stuff. So we'll touch on it today for sure, but just wanted to let you know. Maybe one more. Does one more group want to share any questions or anything that came up for them in their small group?
Hi, my name is Otis Ward, and Mike, we discussed substance abuse, but one thing that really gets me and how to address is the systematic discrimination that we have with substance abuse, how alcohol and different drugs are being distributed in certain communities. If you look at a upscale neighborhood, you won't find liquor stores. But then when you go in the inner city, or what we call the hood, you'll find a liquor store, maybe two in 1 block radius. So sometimes you have to look at my focus is I understand the whys. Many have been traumatized and go through traumatic life experiences all through their lives, and they use substance abuse as a crutch. But how do we deal with these with the systems that are in place so that we can deter individuals from dealing with the different types of substances that are introduced to them at an early stage?
Mm-hmm. Yeah, there's a wealth of research and information on institutional racism and systemic racism, and substance use is not exempt from that. So you're absolutely right in terms of where things are placed strategically and what that looks like for various communities of color specifically. So that's a very good point. Thank you for sharing that.
Well,
all right. So expectations of the training. One of my biggest things, I put this photo on here because we're virtual. So when I was initially looking at photos to put in the presentation, they were all in person. And I thought this is not accurate to what we're actually doing. So the expectations of training look more similar to what is presented on this photo in the context of crowd participation. So please, please, please use the chat. The people who are co-facilitating will look and find questions, and I'll do my best if I see something to stop and acknowledge it, because that is really what makes these types of trainings rich. And I have all the information in the world, and I can talk for hours on end about all of this stuff. But if it's not beneficial to you and what you're doing in your work, then you leave feeling a bit empty, or maybe feeling a bit like you were robbed of your time. And that is not something that I want. But in order for that to not be the case, there is an expectation that you are participating. We will continue breakout groups where you'll have that small group discussion, which can really be rich. I'll also have polls, so that way I can get a sense of where the group is. Questions and answers are great. I love questions. If I don't have the answer, that's okay. I don't know everything, but I'm happy to do the research to find out for you. And I just want to set expectations in the context of, this is a broad information scope. So this is an introductory training, which means we will cover high-level information across several topics. If there are any topics that you feel like, hey, this is really, I want to learn more, or I want to go deeper, I can do trainings for those. I have trainings for those, but this is not that training. We're not going to dive deep into one category. We're going to kind of broad stroke everything. So if there are things, and I think Leah put it in the chat, if there are things that you want to see that weren't covered, or that were just covered briefly in this training, feel free to let me know, or to let the facilitators know. So that way I can either develop or represent a training that I've done in the past for you all, or come to other organizations as needed. So those are the expectations. The flow is pretty simple. We'll start with defining substance use at the top. We'll talk about how we'll talk about levels of care of substance use. We'll talk about treatment in community settings, and then we'll wrap up with how to talk to clients about substance use. This is kind of the, like I said, broad spectrum of topics that we'll cover. We will have a break at the halfway mark for 15 minutes. So I'm gonna try my best to get us working on time and making sure that time is paid attention to. So my goal is that by 10:30 we'll hit our 15-minute break. But obviously this is the virtual world. So if you need to go to the restroom, if you need to get a drink of water, please don't hesitate to do that. But just want to set expectations that we will have a 15-minute break in the middle. Some training limitations. So I have this, knowing your limitations. Just because you can hold your breath underwater doesn't mean you can live there. One of the things that I recognized as I was putting this training together is there's so much information that I could fuse into this training, and time is always a factor. So I always find myself at the end rushing through the information that I have, because we had such rich conversation throughout. And so I hope that you all can give me grace in that. I would love to answer all the questions and talk about all the topics, and we're a bit limited. This particular training is more informative than it is practice oriented. So you will get some technical skills of what you can do, but in general, it's more informational about the how and the why and things of that nature. And the scenarios are endless. So of course, there can be a situation where you have a child who has, you know, two parents who are using and takes care of their siblings and is going to school and is going to work and is smoking marijuana, but is still getting good grades, and you want to figure out how to help them. Yes, that is a scenario. I've experienced that scenario before. And we may not get to those, like I said, specifics, but again, I'm happy to do some deeper dives in other trainings if those would be beneficial for all of you. Let's see. Any questions before we jump in to the content? Okay, let's go ahead and jump right in. So defining substance use. We're going to start this one with a poll. What is the most common way you describe this population? So when I say this population, I say, you know, substance use, anyone who uses substances. What is your go-to or common language that you use when you're talking about this topic? Yep. Okay. So it looks like of those who answered this question, thank you to those who answered. Most of you describe this population as users. So that's helpful information. And we'll get into a little bit more about this in a second, but I want to show you all a short video by the late Maya Angelou regarding language. So I'm going to go ahead and start this.
Words are things, I'm convinced. You must be careful about the words you use, or the words you allow to be used in your house. In the Old Testament, we are told in Genesis that in the beginning was the Word, and the Word was God, and the Word was with God. That's in Genesis. Words are things. You must be careful. Careful about calling people out of their names, using racial pejoratives and sexual pejoratives and all that ignorance. Don't do that. Someday we'll be able to measure the power of words. I think they are things. I think they get on the walls. They get in your wallpaper. They get in your rugs, in your upholstery, in your clothes, and finally into you.
So what did folks get from this video? Just that brief video. Feel free to unmute yourself or pop it in the chat.
So when I was watching this video, oftentimes I actually have this conversation with people in my family, people that I'm around, that the power of words is so huge. And oftentimes it's not what you say, it's how you say it. You can get the same message across by using different words. And I just think it's so important when we're talking about something so sensitive. You know, substance use is so sensitive. That we think about how we talk about it when we're talking about it in the community and to people who are particularly using different substances. So, yeah.
Mm-hmm. Lauren, your hand is up.
Yeah, I love this video. I think it's beautifully illustrated about the importance of words, and just thinking about, even from a standpoint of children development, that the words that they hear in their household actually grows their vocabulary. So just them, whatever words they're receiving and they're hearing in their home, that is the words that they take into their life. And so I think the way that, moving into this training, the way that we talk to people are, because the words are coming out of our mouth as we're talking to them. So I think that it's beautiful, and we need to remember the importance of them and how we handle them.
Absolutely. Thank you, Lauren. A couple chat folks said it can carry so much stigma and judgment. Some said, it's how they think of themselves and how we're referring to those we work with. Words are impactful and important. Use them the right way and with caution. Language is powerful. Words are powerful. How community and society views us. Absolutely. Anybody else? There's another hand raised. Pamela.
In the work that I do, I always introduce to people who are substance users previous experience to navigate through my process when working with them, so that they are not alone, because I am a recovering addict. So I try to support the people with experience and knowledge versus discrimination or finger pointing to make them look less than.
Mm-hmm.
And then word, like the person said about using words in the home, I think it's also based on society. Like African American people, they use slang language, or they use what they, like you said, what they grew up on.
Mm-hmm.
But it's a cultural barrier, and some people, they don't understand that. Just like the guy stated about the liquor stores in the area and so on and so forth.
Mm-hmm.
It's just about what you do after you have experienced that, and what you can do to support the person who is experiencing that specific situation. Me personally.
Absolutely. Thank you. So this is really critical. And I start all of my trainings with a discussion about language, because that is honestly one of the first aspects of substance use treatment that cuts people off, because of the things that we say or how we describe the person who's using substances. So it's really important to use, in general, clinically speaking, person first language. And what that means is you say a person with substance use issues or a substance use disorder, a person who has. So you're identifying the person as a person first, regardless of what they do, how they live, you're describing them as a person initially, and then follow that with whatever they're doing. So you're separating out the person and their behavior instead of merging those two together and infusing an identity that doesn't necessarily belong to them, or an identity that they don't necessarily align with. And so this video and also the poll really, it allows us to see where our subconscious biases come from. Because if we're saying, oh, these are users and these are not users, we are identifying and labeling people as their behavior as opposed to people as being people. And so it's really important, just generally speaking, to be attentive and mindful about the way that you use language. And so there is a resource called the Addictionary that it's evolving, it's a living document, and it's got some examples of ways to kind of shift your language to more person first, less stigmatized, things like that. But what I do want to note and highlight is the community and the culture. So there are situations where you have people who are in recovery and they are very proud of the fact that they are in recovery, and they self-identify as addict. So when you're in community settings, it's really important to hear what people are saying and the way in which they're saying it, because if someone says, I'm a recovering addict, you don't come to them and then say, don't say that about yourself. You are a person in recovery. That's not your place. That is their identity, and that's what they own, and they're proud of it. So you have to be really mindful and attentive to that particular situation as well. You may have someone come in same way, yeah, I'm an addict. And in that situation, it's more appropriate to say, well, how do you feel when you say that? Is that how you identify, or is that just something that you do? And open up the door for conversation. So tone and context is really important as well. Generally speaking, you want to assume, if you have to, that you're going to go in with person first language until the person you're working with or the person you're interacting with identifies otherwise, because that does happen. And that is something that you can risk taking away from them if they identify and it's theirs. So Leah, thank you for posting the dictionary in there. In some cases, like I said, it's a living document. So I didn't put it up here because some of the words that they use, I still don't necessarily agree with. This is still a very new concept in the addiction medicine world because of the fact that there's such a heavy emphasis in community recovery groups that addict is not a bad thing. And it's not a bad thing. Like I said, it's really dependent upon your environment, who you're talking to, and how they feel. But in some cases, it is something that is shaming to folks and they struggle with it. So generally speaking, the consensus is that we're trying to get more to person first language so that the substance use world is more respected, less stigmatized, better understood. Another example of this is clean versus dirty. This again places this subconscious bias on people who use substances. And this is relating to drug tests. This is relating to the types of drugs that are used and substances that are used. And so you want to get away from value-laden language because, as the late Maya Angelou said, words get into your soul, words get on your clothes, they get in your walls, and then you start to internalize that. And this is especially true when we're dealing with kiddos or when we're dealing with people who experience trauma, which is most of the population that you're working with, especially now. So you have to be really mindful and attentive in that regard. And that is literally the first intervention that you can utilize when you're working in community settings with people who have substance use concerns. So I think Hannah had mentioned in one of her questions regarding substance use, like, I don't know what use is or abuse versus addiction. So here's your answer. Quick and dirty. Use can also be labeled as experimentation or social use. So this is casual. The substance use is not necessarily a priority for folks in this category. It's generally done in group settings. So we're going out after work, or we're going out, we're doing this after school every once in a while, special occasions. There may be some cultural pairings. So I have wine with dinner, or I do this with my family, or I do that with my family that is surrounding substances. So you'll want to keep that in mind, the cultural piece or the cultural component. But that's general use. So we're talking about casual, there's no binging here. There's no excessive use. There's never been a problem where someone has said, you're drinking too much, or, oh, you always smell like weed, or anything like that, or, are you lethargic? What are you taking? There's nothing to that effect. It's very casual. And then we transition to abuse, which is more excessive use. So it's still not necessarily every day. It can still be casual, but this is where the binging may come into play. This is where, in some cases, you'll see folks use it because they're anxious. And when they are about to have a big meeting, or they know that they have a big project due, they may overdo it because they're anxious or they have some other things going on. It's generally more of a priority. So once I get home from work, I'm stressed out, so I'm gonna have a drink, or I do that every day because I'm stressed all the time. And like I said, there's an increased risk for binging behaviors, and there's an increased risk for, maladaptive behaviors like drinking and driving, making poor decisions, things of that nature. And then we have the addiction, which is severe use. Generally, this is associated with legal implications. So they've already had something happen to them where they've had interactions with the law, or they've already been arrested for substance-related issue. They have put themselves in dangerous situations, or they've put their family in dangerous situations. So drinking or using substances and having a newborn, which can lead to neglect. And then they depend on the substance. So this part of addiction is called tissue dependence. So generally speaking, this is kind of like with the opioid crisis. So to an extent, if you use enough of opioids, your pain tolerance naturally decreases. And so when you experience smaller amounts of pain, if you're not using the medication, it becomes exacerbated and it's very, very painful. You can stub your toe and, you know, it would be a 3 if you didn't have tissue dependence, but it's like a 20 because you have tissue dependence. So this is that stage, right, where you get to a point and you're feeling the pain or your body actually physiologically needs that medication or that substance to function. And this can look in alcohol use disorder, having to have a drink in the morning because of, you need to be able to function like your new norm is being intoxicated or buzzed. The DSM-5 criteria for a substance use disorder is here. You have substance use disorders as a problematic pattern of use leading to clinically significant impairment or distress. Now, I want to say that is very subjective, but if someone's coming to you for substances, chances are you can check that box. But in a lot of cases, this is based on one's clinical judgment or their perspective. So if you're a teacher and you see a kid always coming to school with red eyes and sluggish, that's clinically significant impairment, not turning in their work. They're not actually engaging in class, things of that nature. In addition to that, looks like there are 4 of the 11 symptoms in a 12-month period. So what's that? 0 to 1 criteria, there's no diagnosis. So there's not, in the DSM-4, there was a diagnosis for substance abuse based on a single criteria, but now that is not the case. If you have 2 to 3 symptoms, you're mild substance use disorder. 4 to 5, you are moderate substance use disorder, and 6 or more, you have a severe substance use disorder. So I'm not going to go through all of these criteria. You can look in the DSM-5. If you can use a little desk reference. There's a short, small book like this that you can get, or if you want to get the huge book, the DSM-5, you can as well. I will say at the end of all of that, you want to make sure that you're following the DSM-5 for formal diagnosing of substance use disorders. So never go off your gut. Don't just say, oh, I feel like they have a substance use disorder, so I'm gonna go ahead and say it. In a lot of cases, substance disorders still are not, they're not approved by the state. They don't get paid out much. So a lot of people don't use them. But when in doubt, follow DSM-5. Yeah, Pamela. All right. So Pamela, you were asking about the DSM-5.
Yes, I was asking you when it was created, and then the screen that you had before that when you was discussing it. How did you guys get that information?
So this is all in the DSM-5. Are you talking about this? The substance use criteria?
It was the one before that, because when you were describing not how to diagnose a substance user, I was just wondering, and then the slide you had before that, because in treatment, someone who is severely an addict will fall under abuse and not addiction. So I was just wondering where you got the information. And then when you said the DSM-5, I was just wondering where it came from and how it was created, because in treatment, that is total opposite. So I was just wondering.
Yeah, so the DSM-5 only uses substance use disorder. They don't use the term addiction or dependence anymore. and that changed in 2013. So this slide where I'm saying substance use, abuse, and addiction, that's kind of the language that we're all familiar with. But formally speaking, the DSM-5 transitioned in 2013 to use mild, moderate, and severe substance use disorder as opposed to abuse, addicted, and dependent. Does that answer your question?
Yeah, thank you.
You're very welcome. Other questions? All right, so moving on, we're transitioning into levels of care for substance use treatment. So back to a poll. My question for you all is how familiar are you? So with substance use treatment in general, are you familiar with ASAM criteria, levels of care continuum, unfamiliar, familiar with criteria, but not levels of care, familiar with levels of care, but not criteria? So this is a poll that I'd like y'all to fill out. All right, so unfamiliar with both, which is great. That's what I was hoping for. Otherwise, this may have been a little bit of a snoozer for everyone. But we will, that's what we're going to go into to talk about at this point. So substance use level of care, again, formally speaking, CARF, the Commission on Accreditation of Rehabilitation Facilities, is the certification organization, the umbrella. And ASAM, the American Society of Addiction Medicine, that's where they get their accreditation. So if something is CARF accredited, it's also ASAM, it follows the ASAM level of care. And we'll go into that. But generally speaking, the levels of care are detox and withdrawal. So that's intended for stabilization. This is someone who is in active use. Outpatient, this generally includes therapy, groups, case management. Excuse me, this is probably where most of you will fit in. Inpatient services, this is intensive medical care for a short period of time. And then residential, which is ongoing multidimensional care. And generally speaking, difference between inpatient and residential is that the client is more stabilized in residential than they are in inpatient, and it's a longer stay. So these are the general levels of care when we're talking about substance use that people would go to, and maybe that you would refer your clients to if they're dealing with substances and they're struggling. But like I said, most of you will probably fall in the outpatient setting where you're doing case management, groups, individual therapy, things of that nature, and you may just happen upon someone using substances. Now, I do want to say that just 2 weeks ago, ASAM put out a survey, the American Society of Addiction Medicine put out a survey to change their levels of care. So this training was developed, and then thereafter that came up. So these are currently the levels of care, but it sounds like there will be some transition to more appropriately label the levels of care from the perspective of ASAM. I also want to mention that ASAM is not the end all be all. It's just one of the larger organizations when it comes to specifically substance use disorders and treatment specifically. So not necessarily psychoeducation, but just treatment specifically of substance use disorders and the minimum requirements for treatment for someone to say, I am a substance use program and I provide substance use related services. So it's very similar for adults and adolescents. The levels of care are seen as being on a continuum of 0.5 up to level 4. And similarly, like I described in the previous slide, you have prevention, early intervention, sometimes that's detox. Then you have outpatient services, and then you have intensive outpatient or partial hospitalization services. That's one of the categories that ASAM is considering splitting out into 2 separate levels, residential and inpatient. This is where you start to get a little more nuanced in what needs to be provided and who needs to be available on staff in order for you to say that you're providing substance use treatment. And then level 4 is intensive inpatient, which is primarily medically managed and not as much therapeutic work. So you're still doing therapeutic work, but the priority is the medical management. So this is someone who may be on Suboxone or buprenorphine for just working towards transitioning someone off of the medications that they're on. Or this could be something that looks like a more harm reduction, like medically managed needle disposal, where you have a doctor on staff as well. And this is the case for adolescents and adults, but like I said, it will be changing soon. And then we have Acm Criteria, which is also looked at on a continuum. Now, what I will say is Acm Criteria is something that was birthed out of what I call a biopsychosocial model, and we'll talk a lot more about that as we move into the training. But the criteria that Acm has developed is that there are 6 dimensions of multidimensional assessment to determine whether someone has a substance use disorder or not and how they're struggling. So acute intoxication and or withdrawal potential is something that is weighed to determine if someone has a substance use disorder. Biomedical conditions and complications, emotional or behavioral or cognitive conditions and complications, their readiness to change, their relapse, their continued use or continued problem potential, and their recovering or living environment. So do they have a place to stay? Does the place to stay have a lot of people who use substances? Are they supported in their living environment? How are they recovering? So these are all criteria that match with this previous slide of levels of care to determine where someone would go in treatment based on Acm. Are there questions here? All right. So we
I have a question.
Okay.
Sorry about that.
That's
I want
okay.
to know, like in Black communities, it seems like it's very little treatment centers, like where you could literally go to get help.
Mm-hmm.
Why is that?
So I will say the treatment centers themselves, and this is definitely my biased opinion, most of the treatment centers themselves are trash in general. So there are not very many like that I recommend that are strong treatment centers in general. And the treatment centers, depending on what you're looking at in this levels of care in BIPOC communities, you actually will see a lot of outpatient services kind of doing double duty. You won't see residentials in general. They're far and few in between, but they tend to be in more affluent areas because people can afford to maintain them. And it's think of it as a franchise, right? So if you can afford to buy a building to build your own Krispy Kreme, then that's what you're going to build, and you have the money to do that. So there's definitely a huge financial component as to why they're not in poorer neighborhoods versus more affluent areas, and also just sustainability. So Thunder Road is in downtown Oakland, and they had a lot of turnover, but that was a residential facility for adolescents for a long time, but they had kids running away. They weren't staying there. They were able to go, off campus, and it was easy to get substances in and out, and there weren't very many staff who actually wanted to work there. And so sustainability is a big part of it too. And I don't know, Pamela, if you wanted to add to that or if you had a separate question.
So there is a lot of local residential treatments now. Since Alameda County has took over, that the treatment service is very limited. And so you start off where you can go into a treatment facility for almost 2 years, but since Alameda County has changed that, people are going into treatment for 3 months. That's not enough time to get services. And the adolescents, it depends on the trauma that they have experienced. and the level they are at to recover.
Mhm.
So therefore, like I said, due to the Alameda County crisis and the amount of service that the person can receive that is limited, in 3 months, you cannot get help.
Mhm.
And I'm just telling you from experience, I was in a local treatment facility in Alameda County, and there are a lot here. It's just about how Alameda County has changed over how long this person could be in a bed space. That's the turnover for us. And the outpatient services has already been there. Those are for people who are strong in recovery. Once they have did treatment, they can go to the outpatient service and continue. But you cannot start off the outpatient services if you're really severely an addict. You cannot survive that way. So I just think that it's really hard since Alameda County has changed the limitations, but there are treatment facilities here in Alameda County, and they do work. They, like you said, you got to want to do this.
Mm.
You know what I'm saying? I was in a
Mhm.
shelter, and the people at the shelter was ridiculous. How could you work like this? How could you want to support someone? You got to love what you do.
Mhm.
Like you said, that the turnover rate in group homes right now, people are coming in there with guns and stuff. These people got to live their life too. So just
Yeah.
imagine if the safety is a
Right.
concern, then there is no way that these places will have a good outcome. This generation is very different, and it's hard to survive in a job where you feel that you're threatened. So
Yeah.
you have to really have a passion for these people to do this. So I'm just
Absolutely.
speaking from personal experience, and I am saying that they have to want to recover and get the support that they need. But in 3 months in Alameda County in a bed, you're not going to recover. So that's just what it is.
So there are a couple of things. Thank you for sharing your experience, Pamela. There are a couple of things. One person, Diane, said the changes about length of stay have been insurance driven. You're absolutely right. And as I mentioned, and I want to make sure that I drive this point home, the facilities I'm talking about are ASAM and CARF accredited. So like the MPIs and facilities like that you may be talking about, Pamela, those may not be accredited facilities. And that's why I say that there aren't necessarily a ton, because they have to have that CARF accreditation where they have the minimum number of staff, minimum number of beds, food allocations. For adolescents, it's very strict because they have to have a school curriculum, they have to have activities for them. And there are several things that have happened in group homes, which are not accredited, that are not appropriate, or things that I had to do a report when I was working at Kaiser. There was a facility in Modesto, I want to say, and one of my kids was sexually assaulted by a staff member there. And that is very common. And so it's unfortunate, but a lot of facilities are not accredited, and they're just providing services based on very limited resources. And they're kind of trying to kill two birds with one stone, like I said, at the outpatient level. Because when I worked at the outpatient level, a lot of those folks should have been in residential, but they didn't have the coverage to go to residential. So they had to be an outpatient, and we had to make it work. And a lot of you are probably experiencing that too, is that where are we going to send them? There's no beds, there's no space. And there's also just, they're not able, they can't financially sustain it. So I respectfully, Pamela, disagree that there's not enough and there's not a lot that are actually quality facilities that have the resources needed to work toward people who need recovery and who need that time, and who need to be away from their environment. Like, for example, one of the places that I used to always refer my kids to and my adults to is the camp. The camp recovery is in Scotts Valley. That's by Santa Cruz. It's in the mountains, gorgeous facility, well away from everything that people in the Bay Area deal with. And my kids get an opportunity to be out of their environment for a little bit. Not to say that that is the solution, because it's definitely not the solution. But when you're dealing in early recovery, that is a great way to help someone start their process or their journey, is getting them out of that environment so that they can recognize and believe that they're able to get through, and that they don't have these demons or these specific things coming at them, or they can deal with the trauma without all of the excess noise for a little bit before they come back into that environment. They've practiced some of their tools, they've practiced some of those skills, and they have at least some semblance of a foundation that they can step down and come back to. So that way, when they do get back in that environment, they're not like fish out of water and trying to figure it out. And so, like I said, these are specific to the the American Society of Addiction Medicine, but not necessarily what we do on the day-to-day, because there's so many factors that have to be taken into consideration. The big one being insurance and what is covered and what is not covered. And so you, unfortunately, with this population, and this is a fight that we're battling right now, is parity between mental health and substance use, like making sure that substance use treatment is equitable to mental health treatment services. It's covered by insurance. There are adequate facilities that have the minimum requirements, that are willing and able to serve this population, and people aren't fearing for their lives when they're doing this kind of work. And there's also, and we'll talk about this once we get to the next phase of this training, but we'll talk about some of those nuanced things when it comes to parents not being involved, for when we're talking about kiddos and adults who have a partner who is abusive. Jacqueline said, this is why we need universal health care. That's a whole nother conversation, Jacqueline. But yeah, I mean, there are several factors, and this goes back to my beginning slide of the scenarios are endless. And when we're dealing with substance use, I hate to say it, but it's still so new, relatively speaking, to folks, because it's been historically stigmatized as a moral flaw, as opposed to being an actual mental health diagnosis or diagnosis of some sort. Diane, you raised your hand.
Well, I can't address working with adolescents, but I work in a program. We're an outpatient program for women in recovery with their very young children. Although we can take, we never close the door. People can keep coming back. But the residential part of the program, which is what you're addressing, I can't believe the changes in that program. And they seems to me it happened about a year ago. We used to have the luxury of telling women to expect to stay in the program for a year. And it was the understanding of many people. Again, I'm not the trained substance abuse counselor, but those women who were able to stay in the program, commit to it for a year, did better, had a greater chance of not relapsing. But then we went to this model that's required by Medi-Cal in the city and county, and I'm sure it has to do with this Acm Criteria. We went to this model called 30, 60, 90 day. And so the first 30 days, that's easy to get access to, relatively speaking. But then there's a review at the end of the 30 days, and to make it possible for a client to stay for 60 days, which still isn't enough, but make it that, I guess our program has gotten kind of pretty creative about justifying keeping people for 60 days. And then the next cutoff is 90 days, and 90 days just is not enough. So we have an adjunct program to our residential. It's a house down the hill close by. Anyway, and of course the women are expected to make use of outpatient resources as well. But it's definitely, I can't believe the change in a year's time. So, yeah. But there are pluses and minuses. The longer stay, people got very restless. Their commitment to being in recovery would waver. They missed they sincerely miss their previous relationships, including relationships that weren't useful.
Mhm.
And so they would often leave the program without a good plan and go stay with the person who had, usually the father of their child and also the provider of their substances. But anyway, there are pros and cons to all these different models, but this 30, 60, 90 day, I find personally, since the program has gone to that, they've been giving me only referrals of people who are been in care for a longer period of time, because you just have to work really fast
Yeah.
with and there, especially during the pandemic, the agencies that you want to refer to people to, they're not able to work as fast. Everybody's lower staffed than they were before. I don't know,
Right.
a lot of complications.
It's a very complex issue. And unfortunately, one of the things that also comes up in this, and I think I mentioned it before, but there is a huge sense of piecemealing programs together for people who have comorbid substance use and mental health issues. And so these criteria and these levels of care are really intended to target folks at more effectively at the stage that they're in. However, there are a lot of limitations and they can create more barriers to treatment. There are some facilities and insurance coverages that will only approve 7 days and they'll say, figure it out. You need to send another updated message in 6 days for us to approve another 7 days. And you have people who are, you see in front of you, they're going to die. Like they're literally going to die. And this is for those of you who are not in the substance use world, this is on one end of the spectrum. There's definitely another end of the spectrum where you have people who are casually using, not ready to stop. We'll talk about that too. So don't feel left out. But I do think it's important to recognize, and this is part of why I started study, was to really advocate for the equitable and appropriate treatment, because treatment gets really stale really quick with substance use. The same groups, after you run through a cycle, it's kind of like, what am I doing here? A lot of folks feel that way. I went through this 4-week cycle and now we're doing the same thing over again, and there's benefit to the repetition, but that doesn't mean it has to be exactly the same. There are ways to kind of be more nuanced about it and be more specific to that person's experience and things of that nature. Jacqueline said the state should have to open a treatment center in the location where they issue the liquor license. That's a great idea. Utilization review is the part of insurance that allows them to easily deny people and save money. So utilization review is, depending on the organization that you're in, determines what UR does. So I know specifically at Rogers, UR really advocates for more time. They go to bat for the clients. But in some cases, I mean, that's a lot of work. They have to go through all of the notes and they have to find medical necessity, which, to your point, Diane, about things changing in the last year, one of those reasons for change is the definition of medical necessity and who can define medical necessity. So previously, the insurance companies defined what medical necessity meant. Now it is up to the attending psychiatrist or medical provider to identify medical necessity. But what we run into, and this goes back to the ASAM levels of care issue, I'll go back to that slide. One of the issues that comes up is we don't have a lot of medical doctors or psychiatrists who are trained in substance use to determine appropriate medical necessity. So now that this law is in place, it was intended to help keep people in treatment for the appropriate amount of time that they needed and put that expectation or responsibility in the hands of medical providers. However, several of our organizations, several of these places that we send people to, they have a medical doctor per diem, or they have a medical doctor who's only there once a month, or they have a medical doctor who just calls in. And so that limits the ability for that law to actually get legs and make progress, in addition to the fact that if nobody says anything, then nobody's going to do anything. So a lot of people don't know that that law has gone into effect, that the medical doctors can advocate for medical necessity and keep people longer against what insurance has said. The power has been taken away to an extent from insurance companies. But a lot of people don't know that. And a lot of medical doctors don't do that because they either are not on site enough to do it. They're just as burnt out and overwhelmed, or they didn't know. And they just take insurance's word for it. So in the ASAM levels of care, the only one that actually requires it or is formally labeled that it's medically managed is the intensive inpatient level, which is level 4. However, in most cases, you'll have a psychiatrist or a medical provider in levels 1 through 3 as well. And obviously in the detox withdrawal section, but that generally is 7 days. Because detox and withdrawal doesn't necessarily take that long, depending on the substance that you're withdrawing from or detoxing from.
Ms. Jones, did you say that you can ask their medical provider for an extension? Did I hear you
So
correctly?
yes, essentially the medical doctor can speak, they would do what's called a peer-to-peer, and they would speak to the physician on the side of the insurance company to advocate for more time.
So that's only if the person is in the recovery at the time or in a treatment facility, or what about when the person is not able to get like they're not in a facility where this is being done?
Yeah.
Are you able to like vouch for them to go through their Medi-Cal or no?
You can tell them, but a lot of doctors are hesitant to do that because they don't know the patient or the client themselves. And so that's putting their license on the line to advocate for someone they haven't yet assessed and they know nothing about. So that wouldn't be something that they could do. They would need to be connected with a medical provider, psychiatrist of some sort, and they would need to be in the review process. So they would need to have already been approved to go to a facility, or they would need to be in active treatment. So if they are currently being seen by a therapist and a psychiatrist, and you both think, hey, this person needs residential or this person needs inpatient, you can submit that request to their insurance. And then if it's denied, then the medical provider can request a peer-to-peer in which they would talk to the insurance carrier's psychiatrist or medical provider to advocate for time due to medical necessity.
Okay, thank you.
You're very welcome. All right. So we are doing really well on time here. We are at our 15-minute break period. So we're about 5 minutes early. So let's come back at 10:40 and we will continue. Getting back into it as we come back. Thank you. I appreciate everyone taking some time for themselves and getting all of this back into the swing of the training. So thank you, thank you. So moving on to substance use treatment in community settings. We're going to start again. I don't know if anyone is familiar with this picture, but the show is called Community. So that's just a funny community settings thing. But anyway, we're going to start with breakout groups again. We have a couple more questions, so we'll probably lean towards the 7-minute mark in the context of, thank you, Emma, in the context of time. But what have you experienced regarding why preteens use? What are your experiences regarding why teens use? Why might someone who's pregnant use? Why might adults in general use? So just the groups, the subgroups that we're going to be talking about, I want to see if there are any preconceived ideas or notions that you have about why these groups may use substances. So why don't we come back at 10:50 from our groups, and these are your questions. Welcome back, everyone. Let's have a brief large group discussion about some of those questions that came up. So what did y'all discuss in your smaller groups? What came out of it? What are some things that, you know, you recognize as contributing factors? Feel free to unmute or use the chat feature. Someone said abuse, neglect, numbing, peer pressure, stress. Somebody said we got to the first two in our group. Okay. Anybody else? Family situation, peer pressure, pain. Do either of you, Jacqueline or Vina, have specific, like, do these go to any particular category or group of person?
Yeah, we were saying as far as the preteens, we said that they were like numbing, probably due to some type of abuse or something going on in their household. And then as far as teens, it was more like peer pressure, just hanging out with, you know, their peers. As far as adults, it was to relieve stress, you know, of the day, you know, also how society pushes like alcohol all day on TV, you know, drink. And then for pregnancy, it was something that they were already probably doing before the pregnancy. And that because pregnancy is short term, they felt like it probably wouldn't harm the child, or it was difficult to come out of that because they already had been using.
Okay, thank you.
You're welcome.
Then we have Vina said that you were speaking about preteens, teens, hormonal changes, abuse, parental figures using. Okay. All right. All good examples. So let's jump into it with a little bit more depth. So I had mentioned that the multidimensional model that ASAM has come up with in terms of assessment can also be similar to what I call the biopsychosocial model. This is more specific to clinical practice instead of the medical model, but they do overlap quite a bit. So essentially, the biopsychosocial model of substance use indicates that the reason or the contributing factors behind why someone would use substances is a combination of these three things. So biological, psychological, and social together, and they interact with one another. It could be one, it could be two, it could be three, but these are the categories in which we want to focus on when we're doing assessment, when we're trying to figure out the why behind someone's use. And it's important to identify the why behind someone's use, not only because it is, you know, good information to have, but also that can create a targeted approach to interventions. So if someone is using, for example, because they want to fit in, if you give them interventions or you provide resources that are, more related to psychoeducation, like, well, you know what this does to your brain, they don't care because they want to fit in. So that's a mismatch when it comes to treatment interventions. And so we really want to, just like with anything else, ensure that our treatment intervention matches the why behind the use in and of itself. So some examples of the biological part of why people might use is it's genetic or biochemical in nature. So there may be a family history. there may be a situation in which chronic pain is involved, and someone is medicated by that chronic pain, or there may be a severe accident. It's really important because you're welcome. Yep, chronic pain is definitely one of them. But it's in the biological component. So it's important to recognize these things, because a lot of times people will develop an addiction or, a severe substance use disorder as a result of something extraneous that happened to them, and they were prescribed medications. Or in the community with lower income, they were in a severe accident and they didn't have insurance and weren't able to get medications and had to find another way to cope or another way to deal with that chronic pain or whatever it is that they experience biologically. Then you go into the psychological side of things, which relates more to personality, relates more to mood. And this can include, but is not limited to, a mental health diagnosis, a trauma history, which many of you mentioned that you discussed in your small groups. It could be stress that you're experiencing. Yes, Pamela.
Do you guys use the biological or genetic when a child is born with heroin in the system and eventually become a heroin addict because they had been born with it in their system? Do you guys use that as that?
That's a little bit different. So it depends on the situation. When I say biological, there is about a 30% genetic component to substance use, but it's not the cause. So it increases, and that's the case for all of these. So the risk of developing a severe substance use disorder is stronger with someone who has a direct family member who used substances, but that doesn't necessarily, it's not correlational. So it doesn't necessarily mean automatically this child was born with heroin in their system, so they're gonna have a heroin addiction when they get older. It just means that they're more susceptible to using substances as a way of dealing with some of this other stuff that they may also experience, or they are more susceptible to abusing that particular substance given their genetic history. But it's only about 30%. There have been several twin studies that have been done where people come from the same parents who have an addiction history, and they grew up in separate environments, and the environment plays a role as well. So it's not specifically really.
So you're saying that a child who basically had a chance to get out of the environment didn't grow up to abuse the drug, right?
In some cases, yeah.
Okay, because I'm talking about cases where people actually grow up and they actually become an abuser to the drug that was in their system when they were born.
Right.
That's what I'm talking about.
Right.
Not a 30%. Most of the people are like that from my community.
So
most of the people use drugs because they had drugs in their system when they were born.
Well, so the risk increases, and we can't do a correlation, or it can't be causal, because there are these other factors that I'm talking about that come into play as well. So the environment, if you're seeing it, we can attribute it to them seeing some trauma and having a trauma history that increases their risk. The ACEs study from Kaiser, it's got like, if your parents have substance use issues, if you've been physically or sexually abused, if you've been neglected, there's a list of several things that also contribute. So we can't say because this person was born with this in their system, that's the reason that they're using substances.
No, not necessarily saying the reason, but when we come from, like where I come from, when we say it like that, it's like more of a 50-50 chance. Not no 30% or AMC or anything like that. What we're saying is from the Black communities where I come from, 9 times out of 10, even if the child is no longer in that home, they're still gonna eventually use. So I don't know what chart that they use for this, but I'm just saying from personal experience, and most of the addicts that I know, parents with dope things, excuse me, are addicts, and they use drugs. So
Right.
we use it from a different scale than from someone who's reading it out of a book or went to school.
Absolutely. Absolutely.
So
What
that's
I'm
why I
saying,
basically was just trying to see if that felt or lined up in that. But basically it doesn't.
no. So basically what I'm saying is it increases the risk, but it doesn't cause it. So you can have somebody who grew up in that environment and they don't use substances. You can have somebody who was born with those situations where they had it in their system and they don't use substances. It definitely, I agree with you, it increases their risk, but it increases their risk just as much as everything else they experience in their life, whether that be what they
I was
see,
just
what
trying
they
to figure out
experience.
where it will fall under these categories, not too much of.
So it would
Yeah.
be a combination of the three. It
Oh,
would be
okay.
all three of them. You can't say it's just this in that case. It's all three of them that they would experience in the Black communities, in lower SES communities. It's not just one thing, it's all of them together, which is why it's important to be able to target all of those things when you're working with them. Because if you just target one, it's like playing whack-a-mole. If you just take them from their parents, that doesn't erase the fact that the community, their support system, the people they love, the people that they hang out with won't be an influence. That doesn't, and then if you take them away from that, that doesn't mean that the experiences that they've had with seeing cousins die in front of them, gang-related violence, or whatever the case, isn't going to contribute to them using anyway. But it's not just one, it's all of those things. And so that's why I said a 30%, because when we're talking about the genetic piece specifically, that only attributes or only accounts for about 30% of the reason why people would develop an addiction or make them more susceptible to having an addiction. Does that make sense? Okay, great question though. Definitely, it is important to keep that in mind, but it's all of these things in combination with each other. So Diane, you had your hand up too? You're on mute.
I just put something in the chat. PBS aired a great documentary. It's hard to take, but it's accurate, called Medicating Normal. And so they talked about two different things. One is how people go from taking medication, pain medication, for the right reason, prescribed by a provider, but how they become addicted to it and that they're inadequately educated or monitored so that to get off the medication when it's appropriate to start tapering off. And then it was combined with same thing in the approach to medication for mental health. We have a lot of medications that are useful in mental health, but if people aren't, if they don't follow through with their provider, or their provider doesn't keep close enough contact or whatever, there's not continuity of care, they can become addicted to the very substances that were supposed to help them. And it's so this, I worked in Bayview Hunters Point. I am more than enough familiar with how medication and drugs are misused in the Black community. But I also got an education about the Latino community when we had women who would be prescribed a medication like Xanax during their pregnancy for symptoms of anxiety. And oh my gosh, I mean, they would just go into an absolute state of panic when it was time to be tapered off, or if their provider didn't want to renew the prescription. So I think what happens is these drugs are they have an effect that neither the providers nor the patients have adequately anticipated that it can be just as hard to get off these things as it is a miracle of how they help when they're really needed.
Absolutely. There's a show, I want to say it's on Hulu, I think, regarding the opioid crisis.
Mm-hmm.
And it really does a good job of showing the biological component
I
of
think it's on
how,
Netflix.
oh, maybe it's on Netflix.
No,
I don't
it's
think it's on
Hulu.
Netflix.
It's
Yeah.
on Hulu.
Oh,
Yeah.
there's
And it's
one on
really
Netflix.
good. Yeah.
Yeah, it is really good. And it is a very, very accurate depiction of how the biological component coupled with the social and psychological aspects of how an addiction really gets there. And it's got several people who are in different stages of life, and all of them get addicted to opiates. And then there's also this very good cultural component that shows just the disproportionate way in which the opioid crisis was addressed and is addressed in the white community versus the crack epidemic in the Black community. And it's just really, I think, what is it called? I can't remember what it's called. I'll have to look, but I'll get it to you by the end. If someone else knows the name of it, it has several great actors, and I'm blanking on all of them. Please excuse the pregnancy fog brain that I'm having right now, but it's a great show. It's on Hulu, I know that much. And it follows the opioid crisis. So
You're giving me an idea for a preventive intervention on this, which is doctors who prescribe these things, maybe, besides talking to the patient about the risks and rewards of taking a medication short term, should maybe require that they watch a video so that they can hear that testimonial you're describing, hear what happens to people who blew off the advice or the relationship that they should have maintained with their provider.
Well, and
their
it's so much
prescriber.
more intricate than that, honestly. And I mean, we could really, Dope Sick, that's what it's called. Thank you, Leah. It's called Dope Sick on Hulu. Great show, very, very well done, and accurately depicted in a lot of ways. So we're running lower on time, so I want to keep that in mind and get back to the training. The social aspect of this model kind of talks about maybe someone's religious beliefs, or maybe family practices, or the environment. And we'll get more into what this might look like for each group. So, biggest factor that we can identify over the last 2 years, we've seen a huge blow up in substance use disorders, is COVID. And it's biological, psychological, and social. So you have unemployment and school closures. So that gives people extra time. That's lack of supervision for kiddos. There's also this great resignation that's happening. So a lot of people are quitting their jobs, going on unemployment, trying to figure out what they're going to do with their life. And so they're develops this existential crisis of, what am I doing in life? Where am I at? What is my purpose? And that can be overwhelming, especially in a worldwide pandemic with worldwide endemics and sub-pandemics that are happening in concert with what's going on regarding COVID-19. We have Black Lives Matter movement. We have the political divide. We have people trying to figure out how to live in a new world. I mean, there are just so many things that are happening that are generally driving people to cope, and substances are one of the easiest ways. And we have convenience. So we have delivery systems, we have Drizzly, we have Ease, we have even Grubhub and Instacart deliver alcohol to your house. So it's very easy and convenient, and it reduces the stigma of going to get a substance because it's delivered right to your home. So nobody knows. Isolation, return to use, is that potential is much higher. So in some cases, people will call that relapse. In the spirit of language transition here, I put return to use because that's a more, it's less stigmatizing. So when you return to use, your potential is much higher when you're in isolation. You don't have the support. Those who go to community meetings to, celebrate recovery or AA or smart recovery or anything like that, those initially, now they're virtual options, but initially they just stopped. They had to transition, they had to pivot. And so a lot of people relapsed and returned to use at that point. Anxiety, specifically health anxiety, is a big one related to COVID-19. Folks feeling concerned that they're going to get sick, and so they're staying in the house. They're not going to socialize. They're not interacting, and we're social beings. We need community, and it's very challenging not to have that. Fatigue. So you have screen time fatigue. You have fatigue because you've been around your family all day, or fatigue that you haven't been able to be with your family and get that support. And restrictions. You can't go here. You can't do this. You have to do this. You can't do that. There's a lot of confusion around what we can and can't do right now. And all of these things combined together and independently contribute to the higher risk of someone engaging in and or developing a moderate to severe substance use disorder. So moving into specifics of the groups that we're talking about. And before I start with the preteens, I do want to note that most of these are across age groups. So they're not limited to preteens, but what I did was really just focus on what may be more prevalent or more causal in teens or preteens versus the things that, are just generally what everybody deals with. But this doesn't mean that this is only why preteens use. So in the psychological or in the biological setting, in context, they may have gotten into an accident. Going through puberty is extremely hard. They may have a history of a medical condition. So more recent research is coming out that substance use in preteens is comorbid with the autism spectrum disorder. Also, seizures and GI complications can increase the risk of someone engaging in use at the preteen level. Then you have psychological factors like a mental health condition, trauma. They're just their developmental stage in life, trying to figure things out, not necessarily knowing where their place is, especially, again, if we add COVID onto this, it gets really clunky. And then we have the social aspect of things. Marijuana is one of the treatments for autism, yes. And a lot of teens I worked with were using substances to medicate mental health issues, absolutely. So you can see how this would particularly pertain to preteens and why they may develop a moderate to severe substance use disorder, because research also shows that the earlier you start using, the more likely you are to have a severe substance use disorder down the road as an adult. So all of these contributing factors, including the social. So we got exploration, we got socioeconomic status, which Pamela had pointed out, and I appreciate very much. And then the perception of substance use in the home. If it is, it's fine, you can use it. There are plenty of kids who I worked with who said, well, my dad lets me drink wine at night with the family. It's not a big deal. So that can contribute to one kind of moving in the direction of a substance use disorder, just given their age and their developmental stage.
Ms. Jones.
Uh-huh.
I also know from personal experience that parents allow their kids and teenagers to use at home.
Yep.
Because they don't want them to use in the community.
Correct.
Or for them to get hurt in the community. So
absolutely,
they allow them to do it because they know that they're going to find ways to do it on their own.
Yes, exactly. So when we talk about teens, sometimes it's more related to one parent using or one parent in recovery. So you have this teenage stage of life where you're still figuring things out, but you are in this transition from dependence to being autonomous and independent from family. And in some cases, I've had situations where parents are in recovery and they've been in recovery for 10 years, but their teenagers saw them in the early stages of their substance use, deep in it. And they model that behavior, even though the parent is in recovery and isn't using. And what tends to happen is this rebound effect where the parent is extremely strict and extremely punitive, given the fact that they know what the substance use and what addiction can do. But the kid is basically like, well, you did it, so why are you trying to stop me? Doesn't make sense. If you have both parents using or in recovery, this can still be the case. A family history overall, or a medical condition as mentioned. Then you have the psychological side of things. You have the mental health diagnosis or trauma. And you have the social side, where there's generally, as teenagers, there's conflict in the home. That's not abnormal to have conflict in the home with teens. What is abnormal is the way in which, or I won't say abnormal, but maladaptive, is the way in which both the parent and the teen cope with that conflict, and conflict being more exacerbated due to COVID and due to being in the house more and not really having a social environment to go to. With regard to the peer group, what we're seeing is a lot of teens are not able to socialize in person because most of their adolescence at this point has been virtual. So we have this digital origin, people who were born into the digital age and people who would be considered digital immigrants. And the natural inclination for teenagers is to be in front of a screen on their phone. That's how they socialize. And it actually increases anxiety when they're not, when they're not engaging on a screen, when they have to talk in person. And so that can increase the likelihood of them using substances and then kind of going down a path. And then, as I mentioned, the age of initial substance use is a big factor for someone developing a severe substance use disorder down the road. Then we have the pregnant folks, such as myself. And the biological piece can be complications during pregnancy. So there are a whole host of complications during pregnancy that can occur that you just don't know until you get pregnant. A lot of stuff can come up. And medication is often prescribed that is specific to pregnant persons so that it doesn't impact the placenta, it doesn't impact the baby, but they are potentially addictive medications nonetheless. And so it's really important when you are dealing with a pregnant population that you're paying attention to what happens, what complications they have, and what may be contributing to why they're using the substance if it was prescribed. General physical changes during pregnancy, Lord knows that pregnancy will change a person's body in ways that they did not know of or did not realize. So those changes may contribute to needing something that is not necessarily going to, again, impact the baby, but will still provide relief to the mother or the pregnant person. Then you have medication-assisted treatment. So medication-assisted treatment is generally used for people who have an opiate use disorder and are tapering off or transitioning to a safer substance that doesn't necessarily give them the same high. But the two frequently most misused narcotics during pregnancy are opiates and methadone, unfortunately. So opiates are a delivery pain management option. So when someone is going in to deliver, they can prescribe or put in the IV opiates. So it's fast acting, unlike if you were to if you broke your leg and you were prescribed opiates and you took the pills, it gets in your system very, very quickly. And that is often something that becomes a misused substance postpartum for pregnant folks. And then you have methadone. Methadone maintenance treatment is a treatment that is used to keep people from using opiates and or heroin. And so recent studies have recommended that you use buprenorphine over methadone because there's a lower risk of addiction development or a misuse of the substance. So it's important to note that those two are frequently misused during pregnancy, and we want to be careful about, we just want to give the risks when we're talking to our pregnant folks. Diane, your hand is raised.
What about buprenorphine after delivery for women who are breastfeeding? I think in our program, I'm working with somebody who's being maintained on methadone, and I think they deliberately kept her on methadone, feeling that was better for the child who was breastfeeding.
Yeah, and it may depend on the person. It depends on what complications or issues they may have had throughout pregnancy. Everyone is different. I just know that methadone is frequently misused during pregnancy. So,
but I think that's one of the issues for those of us who don't work in substance abuse, who aren't physicians, is it's easy to in our program, it's very easy for non-medical clinicians to not think methadone is such a great idea, because and to view it as a drug, something to give people who are, as they say, and this is a prejudicial word that I hate, drug seeking. So I understand that buprenorphine is the state of the art for people who know that they don't want to use for a long period of time. But I think there is a philosophy now for women who have been using, and probably depends on the history, how long they've been using, to stabilize, keep them stable on methadone, at least until the baby, they get through certain stages of development with the baby. And it may be that the nursing is the big consideration, but at any rate,
yeah,
I just say it really, people have attitudes about it. And I worked with I was a consultant in a residential program for women who were using, and they didn't always agree with the people who were prescribing methadone for the women in the program, because the methadone has the side effect of making women very sleepy. And so it makes it harder for the women to complete the tasks of everyday living if they don't have, if they're using a lot of methadone. So I think the methadone works if people have some support, obviously, with the tasks of everyday living, but it's I don't know. I think it's considered to be biologically the best thing for the baby.
there are definitely several factors to consider. And like I said, I have an entire training on prenatal substance use and treatment. So if that's something you're interested in,
yes,
I have a training for it. So this is just a general.
Excellent.
These are frequently used during pregnancy. So it's just one of those biological factors that I want to make sure that people are aware of.
Right. Thank you.
And I think that that's important for us just to know.
Thanks.
No problem. Psychologically speaking, preparation for delivering a baby is very, very psychologically exhausting. So just the considerations that need to be taken, all of the appointments that you go to and the things that you do, and just the unknown in and of itself is huge. It can have a huge psychological impact that you want to keep in mind. And then just postpartum, I mean, baby blues, you got postpartum depression, anxiety, psychosis. There are several psychological factors that can come into play when you're thinking about postpartum that are psychological contributions to why someone may pick up a drink or pick up a blunt or whatever they feel like they need to cope and get through. And you have social. So parenting stress. It doesn't matter if you're first, second, or eighth parent, every baby is different. So keeping that in mind and dealing with that. Childcare fears and uncertainty, especially during COVID. There are several pregnant persons who have come to my office and have said, or my virtual office, and have said, I don't want to take my kid to daycare because I don't want them to get COVID, and, you know, or I'm scared of even healthcare because all of the places are full and everybody's turning me away. Or I didn't call 5 months before my baby was born, and now I don't have anybody to take care of them, and I have to go to work, and I'm a single parent. There are several social factors that come into play. And then if there are other children in the home and dealing with a newborn and being sleep deprived, all of that comes into play. So Nina said marijuana was one substance that some of the pregnant women were using, and they also didn't understand the impact of using around kids, especially. So there was also the education piece. Yes, and I talk a lot about marijuana in my prenatal substance use training, because that is something that has continued to be a prevalent coping strategy or utilization tool for pregnant persons. Then we have the general adult population. So biologically, work-related injuries are very common. Age-related medical condition development, so diabetes, high blood pressure, weight issues, these all happen more in the adult population. Yep, cigarette smoking is a factor as well. Then we have the psychological side of things. So family conflict. At this stage, there may be divorce. COVID has really taken quite a few marriages. Family conflict in the context of children and childcare, like I mentioned. Psychological in the context of boundary setting. This is a huge topic that has really surfaced due to COVID and people setting boundaries with their family members and not having the capacity to take care of their aging parents along with their children, or being responsible for more things than they have the capacity for. Vaping, yep, that is also a factor with young kids. And then social, so work stress, work pressure, unemployment. The unemployment rate has skyrocketed in COVID, which has been really problematic. So essentially, we have these various groups, these subgroups of people who may start or initiate or continue substance use for various reasons. But the take home that I want you to have is that it's never just one thing. All of these things pile up and they all contribute and increase someone's risk of developing a dependency or a severe substance use disorder. So let's transition into culturally responsive treatment interventions in these community settings. So as a general guideline, it's important that you pair interventions with biopsychosocial contributing factors. So I mentioned this earlier, how important it is to match your intervention with what's going on. If someone has a work-related injury and you are focused on trying to get them a social network, that may not pair well. They may not really feel like you understand what they're going through. They may feel like you're just giving them what you give everyone else. This is cookie cutter. This isn't unique to me. Or it just may not fill their need. And if it doesn't, then the substance is always going to outweigh what you're trying to provide them. Also, general guideline, identify the client's stage of change or relationship to the substance. So one of the things that we had discussed earlier on in the training was that, you know, there are people who are in severe substance use disorder mode and absolutely need residential inpatient services. If those people are not ready, and I think Pamela said it very well, if they're not ready to go and they don't want to, you are wasting a lot of your time. You need to match where they are in their stage of change. If they're in pre-contemplation stage and they're not ready, then do some motivational interviewing with them. Just see where they're at, see what it is that's keeping them from wanting to move forward. If they don't even realize it's a problem. Maybe make some observations about things that they've experienced that they don't want to experience anymore. You have to help them get to a stage of change in which they are motivated, ready, and prepared to engage in treatment the way that you might need them to engage in treatment, and not just throw them in oh, you got to go to residential. You're too severe. You can't be here. You have to meet them where they are. And that is in a cultural context too, because if you don't, you're really doing a disservice to folks. So those are important things to consider. So some culturally responsive interventions that may be good to implement when you're working with this population is cultivate a non-judgmental environment. So you want to focus on practical aspects of support. So you don't necessarily want to jump in first if someone uses substances to be like, all right, we need to talk about this weed. You need to cut down, you need to do this, you need to do that. Because chances are there are a million other things that they're dealing with that is making their situation so stressful that you talking about weed is just not going to get anywhere, or alcohol. So focus on the practicals. Housing. Do you need help with housing? How can we contribute to that? Childcare, academic support for kiddos, peer group support, or parenting skills training. So parenting skills training is specific to some of the parenting and general adult contributing factors to substance use that I mentioned. And then you have the peer group support group for kids, maybe teens and preteens, or academic support for teens, preteens, and kids. And then support from the community. So you want to identify where the client feels the most emotionally safe. Now, I will say in some cases where they feel the most emotionally safe is not necessarily the best environment for them, but that may not be the only place that they feel safe, or maybe they need to cultivate a place of safety. So church, friends, extended family, social workers, trusted adults, maybe it's you, maybe you're the one who they feel supported from, and they can come and just talk to you about stuff. And you build that relationship, you build that rapport, you build that connection, and they trust you enough to do what you would encourage them to do. And then you want to focus on strengths-based approaches. So like I said, motivational interviewing, I can do trainings on that to go deeper dive into what that looks like with relation to substance use. Same with contingency management, but in short, contingency management is that people get rewards for the amount of time that they're not using substances. So there's a cost benefit there. Mental health treatment throughout pregnancy and after. So not just related to them using substances, but just supporting someone through pregnancy. I mean, that pregnancy is hard, and there's a lot that can come up. So just having that support may mean the world to them. Psychoeducation on hormonal changes during and after pregnancy. There is also psychoeducation on age developmental stage. So basically, what stage of development is that person at, and providing them with psychoed around it so that they may have a better understanding of where they are. So I have a 22-year-old client who is still living at home and is dealing with the idea of being an adult in a household, being an adult child. That's a developmental stage that comes with a lot of stress and a lot of confusion and a lot of uncertainty around how to navigate. So it may be good in situations like that, when the coping mechanism is to use substances, just talking about that, being normalizing that stage for them, just normalizing it, saying, hey, you know, how you're feeling makes sense. It's not a bad thing. And let's figure out adaptive ways to deal with it and work through it. Some more culturally responsive interventions include holistic approaches. So a lot of times you'd be surprised how therapeutic gardening can be. If you have an area that you can have someone go to and just plant something and see it grow and tend to it and care for it, that can be very therapeutic. Something like going out for walks. We are very privileged on the West Coast to be able to go out for walks, especially during the winter. There are a lot of places right now where that's just not feasible. And then replacement behaviors. So what this looks like in a lot of cases, especially when we're dealing with alcohol, if you're feeling like you want something to drink, get a iced tea instead of getting a beer, or trade out some of the things that you drink for something that may be a little bit more healthy for you. And then truly integrated treatment. So adolescent community reinforcement approach is an evidence-based practice. Community reinforcement approach is an evidence-based practice that you can engage in. And there are several resources on the NIDA website with regard to these particular interventions. Family engagement, if you have it, if you're able to solicit that. And what I mean by family and parent, it's not necessarily just the old definition, but these are supportive adults that our teens spend time with. So that could be an uncle and aunt, it could be a pastor, it could be a teacher, people who support them, want to see them win, want to see them succeed. So figure out who that is and bring those people into the fold, into the conversation of support. Providing parents with support and psychoeducation. In a lot of cases, parents feel attacked when you're doing substance use treatment work, if you talk about their child using and if it is a problem. So it's really important to start with supporting them on what they may be struggling with, if anything, with their child, and working from that angle to then get to, hey, let's talk about how we can reduce, so-and-so substance use. And then group therapy. So peer support for sobriety is definitely available online. There are several different community groups. Some people ascribe to Alcoholics Anonymous, some people ascribe to Smart Recovery, some people ascribe to Refuge Recovery, which is Buddhist oriented. Celebrate Recovery is Christian oriented. There are several different types of community meetings that you can have people go to that are free, that are in the community, that are available to them if they're not able to get into like a group at a Kaiser or a mental health facility or something like that. And then we have harm reduction. So again, another training, whole training can be done on harm reduction, but just to kind of hit some of the highlights here, motivational interviewing is a part of harm reduction. So this isn't necessarily saying that the person needs to stop, but we're figuring out where they are in their substance use journey and if they're willing to consider some other options. There is something called Cali Sober, and this is a harm reduction approach. So typically what this means is you're reducing to just smoking weed. So if you're using a bunch of different substances, you only smoke weed, and so you're considered Cali Sober. But in general, you're reducing to one substance if you're using multiple substances. So you're not drinking, smoking, taking pills, doing bars or whatever. You're just doing one substance, but most commonly it is cannabis. So focus on using outside of the home. So if you have parents, encouraging them only use when they're outside, don't use inside because you have kids, and considering what that looks like. Medication assisted treatment is an option. Restricting maybe to certain times of day when they use substances, or engaging in use in a safe environment. So reduce use when you're emotionally triggered or actively in a depressive or heightened emotional state, and kind of working toward a better sense of understanding oneself and why they might use. So then we go into I don't have a problem. I don't have a problem with substances. I don't know what you're talking about. So like I said, it's really important to focus on the motivational interviewing in that regard. That is the gold standard. But some other things that we can kind of focus on when we are talking about substance use with clients, or how we're introducing the topic. You want to inquire at the beginning as part of your assessment. And this goes across the board. I mean, if you're working with people, it's just like asking how old they are. At this point, for me, it's kind of like, that's something I need to know. It's something I ask everybody. It immediately takes the stigma out of it, because they're aware that it's a universal question and not a question specifically to them. And the earlier you do it, the better, because that lets them know, like, okay, you're not singling me out, or I don't smell like anything today. You're just asking because you asked that question in general. Be transparent. So, you can say, I'm just asking because I have to ask everybody. People who use substances generally respect and appreciate the transparency a lot more. Like, just be real, be straight up. Don't sugarcoat it, because that makes me not trust you. Then you want to be explicit about having the discussion with everyone. Reduce the chances of a person feeling singled out. Motivational interviewing, can't stress that enough. Psychoeducation about substance use in general can be helpful. You really have to read the room with this one, though, because in some cases, people get really upset when you just throw psychoed about, how bad drugs are. So you have to be really mindful about what you're trying to give them information on, and how to present that in a way that's not necessarily judgmental, but just truthful. And oftentimes people will ask you as opposed to you having to tell them. And it's okay to say, I don't know, I can figure that out and I'll get back to you. Using non-judgmental, non-critical language. Again, it's not about you and your experience, it's about them. So regardless of how you feel and what you identify as, the important thing is that you let them tell you whether they identify in that way or not, and start with person first language, because it's not about you, it's about them. You want to encourage consistency in treatment, because that's one of the biggest things that people fall off on. If they don't have that support, then they usually don't necessarily succeed in recovery initially. Another way to do this that's more community oriented is, again, identifying social supports that they have, people they trust, people that make them feel safe, people that they feel like they can talk to, and enroll those people in helping them as well. And then leverage your role. So what kind of role do you play in this person's life? How can you provide encouragement, support, or promote self-confidence in their ability to be able to do this? In a lot of situations, people feel like they're just not capable of stopping. They feel like they're too far down the rabbit hole and they can't make it. But your role, they're coming to you in need of support and in need of belief, like you have faith in them. So just use that to your advantage, and then promote support in other areas of life. So again, biopsychosocial, if there are any one of those areas that's lacking, help them figure out how to make it not lack anymore, or ways to work through some beneficial alternatives if necessary. Emma said, if we're meeting with a client and they express needing support to reduce their substance use, doesn't have resources where do folks go to? Do they start with their insurance? So it depends. If they have insurance, they can definitely start with their insurance. If you're looking just quickly to give them a community resource, like I mentioned, there are several community meetings they can start going to, depending on their comfort level and what they're looking for. You can go to the NIDA website. The SAMHSA website has resources available to you to be able to use and pass out. Pamela, you have your hand raised.
I was gonna say, like, for instance, I just signed a client and she has no support and she's an alcoholic, and she just started to go to meetings, but to tell them, from my experience, to tell them my own truth has been working for my clients, because some people actually don't have a support team. They don't have anyone. So your first initial engagement, when you do interact with someone like that, you might be their only level of support. You know, when these people, family have, you know, stopped dealing with them because, you know, they didn't rent it out. You know, they don't believe if they're going to ever get clean or whatever the circumstances may be. So also, you may be their only level of support. And so I always want to encourage people that, you know, and remind them, because right now I'm dealing with that my client is very excited and happy that she has someone that she doesn't have to feel ashamed with, you know, and that's the main goal, is to make sure that you're encouraging them and standing with them the whole process, because they can fall off.
Yeah, and it sounds like you're advocating the leveraging your role part, which is, like I said, very important, to leverage your role, what role you play in their life. Absolutely. So we have about 15 minutes left. I wanted to leave time for questions, because if we do that activity, then it will take more than 15 minutes. So this is an opportunity for questions if you have any, and then I have just a request for feedback, and we can do both of those in this time.
Gabrielle, can I ask a question?
Sure.
Hey, I'm Emma. I put the question in the chat. I feel like it comes up a lot that folks we meet with, like there's a family member, even I'll have like personal life folks that will reach out and say, like, you know, my brother is a substance dependent, like where should he go? Where do I send him? And I guess that's sort of where I get stuck, is like, are there certain, like, if I know there's like options recovery and things like that, but can they go directly there, or do they need to, for more for like inpatient or outpatient, do they need?
Yep. So they definitely need insurance. Well, they don't need insurance, but it's most beneficial to start with insurance. So generally speaking, especially within the last 5 years, there's been a transition where substance use is getting closer in parity with mental health. And so there is coverage available with insurance. So it would be helpful to have them reach out to their insurance first to see what they have and see what's available. And then once they know that, in some cases, the insurance carrier will do the facilitation and coordination to get them where they need to go. In some cases, they need to unfortunately fail lower levels of care before they're able to get to higher levels of care. And so that may be the approach that they take. In some cases, they'll say, yeah, just call, and then the facility will take care of insurance. So that's one of those. So Otis put family paths, supportive parents. There's a number, 24 hours a day, 7 days a week, preferring text messages between 5 p.m. and 9 p.m., text letter FP, and a counselor will help in real time. So that's a community resource if someone is in need in the moment, right then and there. If you're, like I said, if you're talking about someone getting into continued sustained treatment, then a lot of times insurance is the first mode of action.
So thank you so much.
Yeah, and Venus said the wait time to get into programs can be long in Alameda County. Alameda Behavioral Health is also a resource to find support. Other questions? We got a lot of in the chat, people wanting to dive into more areas, and I definitely would be happy to do like a series on different aspects of substance use, because it's very, very important, and it's very nuanced, and there's so many directions that we can go. Like I said at the beginning of this training, it's really a bird's eye view of everything from a general perspective. But I mean, I could, like I said, talk for hours about just one of these particular, just understanding substance use in general, and I mean, I could go on forever. So I appreciate that and all of the thank yous in the chat. What about least helpful or any suggestions to make it better?
I think if I was going to say least helpful, I would say on the part of not still really understanding or really knowing how to really get help in our communities. You know, how do you really get the help you need? Because not really having like treatment facilities in your community and things like of that nature, or really like nice facilities, healthy groups or whatever. I felt that was kind of least helpful because we really need that. And I still feel like we really don't have the answers to really help our people in a really like large way.
Yeah, no, I agree. I think that specifically in the Bay Area, we are severely lacking. So that is presented in the presentation in terms of quality care. Like we can get people in, but it's kind of like a revolving door, you know?
Yeah. But thank you so much.
Mhm.
I'd like to piggyback off that last comment. That was a great question, but that needs to be addressed by our politicians and decision makers, because you can't get that in the presentation.
Facts.
We get stonewalled constantly. We don't have the funding. We don't get the resources that agencies and programs need. So we need to be knocking down the doors of our politicians and our decision makers so that they'll be more, not say aware, because they're very much aware, but they pay attention to changing some policies and procedures. That is where we start with that.
Facts.
Maybe we need to create a task force.
Yes.
There you go. Yeah.
Yeah. And that's a great, Leah, that's a great idea, advocating for change, because there are several resources and there's a lot of money going into substance use right now, actually. And we could definitely have a whole training on how to do that and how to make the treatment interventions, how to get that money so that we can make our own treatment interventions in our own communities and support our own people, so that it's not just going to these big conglomerates and there's not anything happening to actually improve the community. So that's great.
It sounds beautiful. Yes.
Yeah.
Jones, they actually have a program right now working with the substance of treatment in Alameda County, and they actually got a big grant, and that's Roots Community Center. They're actually in East Oakland moving for the substance abuse and mental health. They have the tiny homes project that they have, that you have to know how to get the money and the funding for what you're looking for, and you got to have a great plan. So people with these nonprofits and stuff, their plans are failing because of what's around us. And the people that's actually getting the funding, they actually have a real good plan. But I really shout out to the Roots community for building the tiny home project to actually start getting the people who want support in their mental health or substance abuse to succeed, because it has to be a plan, and it has to be a great understanding of how they're moving. Like La Familia and Boss, they're actually moving great in the Alameda County for the Black and Browns, but you got to have a plan. So
yeah, exactly. So with the last few minutes I have left, I just want to thank you. Thank you all for being here, first and foremost. Thank you for your engagement. That's what makes these things so rich. Thank you to First Five for inviting me back. Thank you to Beth for having me in the first place. She's who brought me here. And we've maintained a relationship over the years so that I can come back and do these trainings. And like I mentioned, I do consultations for organizations. I'm going on maternity leave, so I won't be doing them for the next couple months. But one of the things that I plan to do is actually apply for some of that grant money that has been dedicated to substance use, so that I can do some consultations and help develop and evaluate and revamp the programs that we do have to make them better for our community. So thank you all for your time. I definitely have resources pages if you want to look at some of the articles that I sent and or some of the articles that I referenced in this training. You're more than welcome to research that stuff. But otherwise, that's all I got for you, and we're right on time with wrapping up. So thank you so much.
Okay, great.
Thank you.
I wanted to just thank everyone for coming. We really appreciate you attending and giving us all your great feedback and attention. Thank you, Dr. Jones, again, for a really amazing and informational presentation. It was so great. And just another quick reminder to do your evaluation when you receive it in your email today, to let us know what trainings you'd like in this topic area or other topic areas that are important to you. I definitely saw a whole bunch of ideas for additional trainings here. So I think we'll definitely be following up on that.